Okay, so this is something that we don't kind of see a lot. This is this is a outside CT that was submitted to a patient that came in for surgery. And this is, so I don't know what it was read as or what happened. And this was smack in the middle of pandemic. So I don't know if this patient just got lost to follow up, or I imagine it's easily overlooked. You can see this very subtle enhancement of mucosa and distal common bile duct. Notice there's no enhancements. I mean, there's no dilatation of the bile duct upstream. I think it's an easy finding to either not notice or maybe say, I don't know, like non-specific, maybe, maybe cholangitis. So but I don't know what they said. Patient came back about 2 years later. And now you can see.
Victoria, was the gallbladder wall also kind of enhancing on that last one?
Not really.
Okay.
Not
little bit.
Not well, it didn't stand out to me a lot, okay. But this kind of did. So this is patient's follow-up in 2 years from the original, and so now you can see that this area, well, first you see that now there is biliary dilatation. Now you can see that there like mass-like irregular thickening of common bile duct, like this rat-like appearance, right? So if you imagine the dark side would be, like if we feel this in contrast, we would see that classic rat tail appearance that we see in ERCP, and this is cholangio. So you can see that here now you can see it's more mass-like in the axial. So we don't often pick it up, this early stage. But
it's crazy that it's not obstructing. I was curious if it was going to be an IPNB.
No, this was resected. It's interesting because usually cholangios are kind of they're sort of aggressive, right? But this one for 2 years kind of hung out. So this was like very early. It's possible that this was in situ of some sort, but this is in 2 years already. Pretty bad. Even still, like in 2 years, there's a less aggressive kind of behavior that we normally see, but this was resected as cholangio. So be careful, I guess. Is a super interesting case. He's a middle-aged man, and this is what we see. And I'll take off the measurements.
Tons of tumor in vein, and then that huge mass on the left.
Right, and you can see that it's hemorrhagic. You can see how horrible, there are multiple intrahepatic, mets. You can see how aggressively this thing enhancing. You can see large left renal mass. So what would you think?
I guess theoretically it could be a renal met with tumor in vein, since renal cell likes to do that. And my initial thought was they didn't have liver disease, right?
No. Right. So this ended up being a huge TIV from renal mets, which in and of itself is worthy, I think, of sharing, because we know that HCC has a propensity to this ugly situation, but it's not exclusive to HCC. It's not pathognomonic. Other tumors can do this, although much less propensity to do that. The reason why I wanted to show you this is that this scan is okay. So if you saw this scan, and what would you guess the prognosis for this patient with this degree of metastases and TIV?
Poor, except that renal cell, they do not have a lot of immunotherapy and other treatments for it.
So this is like a remarkable case. So yeah, if somebody asked me like, what's the prognosis, I would say, you know, dire, right? With this extent of stuff. This is 5 years ago. So this is a follow-up now. So you can see that the original mass shrunken and calcified. You know, we now have cavernous transformation. You know, there's like some chronic thrombus. The tumor, the met is like fully calcified, little bits wherever the mets were. So this is an incredible, beautiful response to immunotherapy. Patient as well. Patient's been great. So to me, that's like the most amazing.
It's amazing. Do you know?
It's like it was like it totally made my day. I actually don't. So it's interesting because the patient was diagnosed here 5 years ago. Then the patient just disappeared. Well, I think we traded somewhere else and came back, and this is like 5 years later. So I actually don't know what exactly he was treated with. But it's like the most remarkable thing I've seen with it. And then my last case.
It's interesting that they left the primary in, but it must have been really responding, because a lot of times they'll still resect the primary because supposedly it feeds the mets and stuff. But it's pretty amazing, and they left it in, it shrunk away.
Okay, so this is the next case. Yes. Okay, so the next case I have. Yeah, so I don't know exactly what happened, but I would assume that it was, you know, that it was such an extensive tumor that they decided, you know, not to provide surgery for him. Okay, so this is not an eye test. But again, I'll take that measurements. But you can see this is just like tremendous metastasis from melanoma. And again, these are like the most melanotic mets I've seen. So in and of itself, it's just very pretty and interesting. Let me just do this.
It went to the spleen too. Was there any in the gallbladder?
There's none in the gallbladder, but hold on, I'll show you. There was something interesting though. So we have this protocol. Ooh, sorry. So we have this protocol where we do the screening pelvis in addition to certain, like, so they do non-contrast sequences, but guess, look what we found here, right? So this is a testicle, and we saw something bright here. Now we run in and out of phase, and then sagittal and axial T2. So here, you know, you can argue, is it possible it's a little fatty thing? And then look, it's dark on T2, and there it is on the sagittal. So this is a testiculum, like a intrasclerotal melanoma met. That was pretty.
Wow, cool.
Pretty, yeah. So yeah, no, he had splenic mets, he had adrenal mets, he had peritoneal. You can see tiny little peritoneal and extraperitoneal implants. Obviously, you know, liver mets. This was done with EVIS, which is interesting, right? Because, you know, this is probably one situation where EVIS is not going to help you because the mets are so bright already. And you can see how dark they are on T2 because of this tremendous melanin content. And because they're so dark on T2, you wouldn't, you know, it would suppress signal on diffusion. You would see nothing on diffusion. What else? What other interesting things we can see here? Probably not, but you know, it's just beautiful example of melanoma. And it's just interesting. Sometimes, you know, we can pick up interesting things on these screening pelvies. And this is the pretty hepatobiliary face with his beautiful, you know, T1 hyperintense mets. That's what I had.
I didn't realize melanin was T2 dark.
When it's this is like the most, you know, when a lot of melanin, it will be dark on T2, but this is unusually bright. Like, not unusually bright, but like this is like a picture perfect textbook case, and most melanoma mets are not like that. They're not this pretty bright signals. A lot of times it'll just be like hypervascular masses without maybe little specks of T1 hyperintensity here and there. But when you have this much melanin, it will be dark on T2, yeah.
That's cool. I just Googled it. And it says they can do T2 star weighted imaging, which increases concept acuity, especially like in neural applications,
Right.
I guess.
Yep. Very cool.
Awesome. Thank you.
History of breast cancer. And we saw an incidental lesion on CT, abdomen and pelvis. And then we subsequently got MR. Well, I have the tissue diagnosis too, actually, but I wanted to share with you and see what you all thought. So the lesion is here. Right there. And then there's no, here, let me see if I can pull up the. So there's no intralesional fat. This is the pre, post, and then let me give you.
How old is the patient?
The patient is, let's see. It's young. I need to, let me pause so I can get the date for you.
And do we have diffusion?
Yes, we have diffusion. Let me share that.
So far though, it's like smudgy on T2 and it has
Yep.
progressive enhancement, right? And you said they have breast
Yes,
cancer?
breast cancer, history of breast cancer, treated breast cancer, about 5 years ago. Diffusion. Okay, diffusion is right here.
It's like shining through.
Mm-hmm.
Don't tell me another sclerosed hemangioma. I feel like if you saw this, you have to say like, we can't, this would be suspicious for a med, especially if it was new.
Yeah, so it was, we had a CT and we identified the lesion. So then we got the MR. And this is a case of bile duct adenoma. That's what
Oh,
the
wow.
pathology showed. And I'm showing you this because I shared this case before a few years ago. And this was my case when I shared it, and it looks just like that case, this case that I just presented. It has it's a subcapsular, and that's a really great thought, like sclerosing hemangioma, because it does have this kind of geographic look, but I mean, not really geographic, but it's T2 intermediate signal. There's delayed enhancement. I think this was a diffusion at the time. This was from like 3 years ago, Arthi, when I presented this case before.
I remember
Yes.
showing this, and I remember saying that my surgeons found one like in the OR.
Yes, and it was like on pathology, and you spoke to your pathologist.
Yeah, and the pathologist said that they see these all the time, and I was like, well, we don't see them. So anyway, it's just so interesting.
So just to review what we had already previously reviewed, and I think it's a good re-review because we don't see this commonly, is bile duct adenoma. They're incidentally, most of the time, they're a tiny minority of the primary liver lesions, 1%, and they're pathologically distinct from things like, what are they? So sorry, it's, these are the other names: cholangioma, benign cholangioma, cholangioadenoma. I've never heard of these things before. Let me see what else. They are subcapsular. So my only other case is also subcapsular, and this one is subcapsular, and they are hypervascular, and they have prolonged enhancement, like you had observed. And because of fibrosis, I guess there's fibrous tissue. So you have this delayed enhancement. But here's that's my second case.
But it's so rare. Do you think that we should actually be calling these or no? Just kind of like be surprised when they, or be, you know, just be like, oh yeah.
Well, I was surprised then and I'm surprised again. Just,
I still feel like we have to like hedge towards, you know, a met, and then if it comes back that's good for the patient.
absolutely.
I agree.
100% agree.
Yeah. Cool.
And then you get these and you're like, oh, okay. You know, you're like, oh, so here's another one.
And then you start putting in your report and everyone's going to start thinking you're crazy. That's awesome. Okay. Roopa?
Yes, Arti. So this was
This meeting is being recorded.
middle-aged female came in with abdominal pain. This was just incidental lipomatous hypertrophy, not much in the chest. She did have little pericardial fluid. And then all the findings were in the abdomen.
Portal vein is thrombosed.
Right.
And wondering if it's related, like a septic thrombus.
So that's kind of what we were looking for. We saw all other secondary signs of like portal colopathy. Here was what we thought was the appendix. It looked edematous. I think there was a small appendicolith here. We were not too sure that was the cause. It didn't look particularly inflamed around it. Then looked for diverticulitis.
What
didn't
about
find
like
it.
colitis of the ascending colon?
We thought it was more submucosal edema and not more from the passive back engorgement and not so much itis. We gave that as a differential anyway. Look for pancreatitis, so look for all the usual suspects. Said something about the colon cannot exclude colitis. This was very acute. And then one other thing we also suggested was like a hypercoagulable workup. So they did everything. So the usual factor 5 laden, most of the other things were negative. The only thing they found was very low antithrombin 3 levels. And then retrospectively, they said that's something that can be seen with sepsis. So when they went back and talked more to the patient, they actually found she had bad periodontal disease and dental caries with pus draining from one of the bottom row teeth. So that was the source of sepsis, which finally they attributed all this to sepsis, hence low antithrombin, hence hypercoagulability, hence portal vein thrombus. So something we learned was like you have to keep looking for the source of infection if you're thinking, even if this is hypercoagulable, infection can be a cause for that. So had not seen a like a pili phlebitis without an intra-abdominal pathology before.
And also you're saying polyphlebitis, suggesting that this thrombus
Well, it is not
infected, but
pili. I guess it's just thrombus, right?
yeah, so you're saying that
Yeah.
the infection causes
Acute portal vein
hypercoagulability.
thrombus.
Yeah, nice.
Yes.
Nice.
But how do you know it's not infected?
We don't. I
We
mean,
don't.
they're treating her with broad spectrum. So the from the tooth pus, they got fusobacterium. So they're treating her for that. And they have imaging scheduled for her next week. So if all this is better, we'll see. And they've put her on anticoagulation as well. So
Does she
we
have,
don't know.
I mean,
which one.
did she have bacteremia as well? I mean, she was septic, it sounded like. So
she was
so
back.
I bet there's like a superimposed infection too.
Must be, yeah.
It is interesting when you have, if the thrombus is septic, the main treatment is antibiotics. Whereas if it's from hypercoagulability and it's acute looking like this, they, you know, sometimes even do a thrombectomy, or they, you know, the main thing is anticoagulation.
So interesting, Arti. They did consult IR for thrombectomy, and IR looked at all her labs and everything. Sed rate was super high. She did have a fever, low grade, although. So they felt she was not a candidate for thrombectomy because it was more of infection superimposed with, like, they truly thought it was phlebitis, and they said do a 6-week trial of antibiotics, repeat imaging. If it's not better, then we'll consider.
Got it.
Yeah.
This is a patient with a history of esophageal cancer and had progression of disease. So it has metastatic esophageal cancer. And I'm showing you this lesion. We have tissue diagnosis.
Looks like a paraganglioma to me. It's so enhancing and it has like central cystic spaces.
And then this is the MR for that lesion.
Nice and bright.
And then here's the post. Let me see. Do I have the? Yeah, here's. And arterial. Yep, bright. And here's later.
Oh my gosh, is it going to be
Yeah.
a hemangioma? No, I still
Yes. So yeah, we did a biopsy and it was a benign capillary hemangioma.
Wow.
So I know we've shown cases of hemangiomas in kind of unusual places. And I think this would fit into that.
I have a question. In retrospect, like now, like the T2 brightness, looks like a hemangioma, but in retrospect, could you have just done a dotatate? Like if you brought up hemangioma versus paraganglioma, and then the dotatate was negative, could potentially just leave it.
I don't think we did a dotatate. We did a PET, like FDG for the esophageal cancer, and it was negative on PET. And then we just biopsied it. So.
But Nelly, with a conventional PET, it would have been negative anyway, right? If it was.
For conventional, over hemangiomas, yes. Well, one of the differential was METs, right? Patient has esophageal cancer.
Right.
And then
We've
had
seen some retroperitoneal schwannomas look like this too. T2 bright with that central, like targetoid-like pattern.
I'm going to give you that the MR was done after the biopsy.
Okay. Nice.
Cool. I do think in retrospect that we could have done a dotatate or a PET MR, and then, but anyway, if I guess you're saying MET was on the differential. I wasn't really thinking it looked like a MET, but if paraganglioma was on there, I would have done the dotatate, I guess, and the metanephrin workup. Okay.
So you would, based on the CT findings, you would not include MET in your differential?
Given how T2 bright it was and like this
we didn't have the MR beforehand.
Oh, still on the CT, it looks so avidly enhancing. Like that to me doesn't really look like an esophageal cancer. Like my first thing was paraganglioma. And then maybe the MR, maybe then a PET MR would have been good because you could do the dotatate and the PET signal. But before that, I would have also recommended metanephrines. But no, MET would have been further down for me. And actually, like I haven't seen an esophageal MET look like that. Like so T2 bright and then with delayed enhancement.
Okay. Here's my next case. Not hard to see. Big renal mass, looks like it's going into the collecting system. There was no venous invasion, not much regional nodes. This was actually a patient with known HLRCC genetic mutation. So we were following, this was surveillance and this has been growing. But the thing that had come up from old scan to new were all these sclerotic mets. So we were not sure. There were some in the spine. Bone scan showed multiple hotspots in the spine, some rib lesions, multiple pelvic lesions. So with sclerotic mets being exceedingly rare with RCCs, we suggested that they biopsy one of these lesions. And the biopsy actually came back positive for papillary type of metastatic RCC. So it's just a reminder that every now and then RCCs will give us sclerotic mets. So some subtypes of RCCs to remember when you see sclerotic mets are RCCs with sarcomatoid transformation. Clear cell doesn't do it that common. I found one case report that said so far, this was in 2014, of course, they said there were only 6 reported cases with sclerotic mets, and of those, 3 were sarcomatoid dedifferentiation and 1 was oncocytic dedifferentiation. I didn't see any case report where HLRCC or the papillaries that are associated with HLRCC came with sclerotic mets, but this was kind of an unusual one. Anybody seen HLRCCs with these before?
I have not.
Yeah, so it's unusual.
You know how you said you were surveilling it? Did it seem like a more aggressive type? Like was it growing, the renal stuff? Was it growing pretty quickly?
No, it was not growing very quickly or anything. Yeah. So that's why this was unusual, but biopsy proven.
Awesome. Can you remind us about just one question about HLRCC? I remember reading about that a long time ago. But,
Yes. So hereditary myomatosis, renal cell carcinoma, cancer syndrome. So you'll get cutaneous leiomyomas. Females can get uterine leiomyomas, and then they call it a specific subtype. It's called Papillary RCC Type 2, based on histopathology. That's the most common renal cell. It's hereditary, runs in families. I don't know if it's autodominant or recessive. That's how much I can remember.
and is this the type 2 papillary that's like the more aggressive type?
Yes, it is the more aggressive type.
Got it. Thank you.
This is a patient who is pre-transplant evaluation. And the patient had portal vein thrombosis. And I guess we're starting to do a little bit of cavernous transformation, just a little. So then I learned from my colleague, Sid Al-Zubaydi, my interventional radiology colleague, about the Yerdel classification. And I'm going to show you what he did. So first, before I do that, let me go over the case. So the portal vein, you have this like kind of chronic thrombus, occluding the almost entire portal vein. The SMV is open. The splenic is open right here. And then he went ahead and did a transsplenic portal, essentially a TIPS placement. So he went through, okay, I'm just making sure there's no, okay. And then he accessed it, he recanalized the splenic vein, and then he put a covered stent. Balloon plastied it and then put a covered stent. And that is right here. And you can see now there's flow in the portal vein. And notice the stent, there's about, like he said, he leaves about a centimeter of normal kind of, the portal vein left. So I learned from him that, because I asked him, like, when do you recanalize the portal vein and when don't you? And so he said, he shared, I didn't know about the Yerdel classification, and this is what the Yerdel classification is. So it's graded on the extent of portal vein thrombus. So if it's, you need, he can recanalize, he said, if it's grade 2 or 3. So if it's just the portal vein, or if it just encroaches a little bit on the SMV. If it's pretty extensive, then he doesn't do it. And if it's already non-inclusive, he doesn't do it. And the goal of this is to make the surgery easier for our transplant surgeon. So the alternative is for them to do grafting and these complex like vascular reconstruction. But if he's able to open up the portal vein, then they don't have to do that. And it'll just be a straightforward portal vein anastomosis with the donor portal vein. And so that's the purpose of recanalizing this, is to avoid those more complex vascular reconstruction that they have to do. And so, but he said, ideally, both the SMV and the splenic vein are open. And when he does recanalize it, he leaves 1 centimeter so that the surgeon has enough length left to recreate the anastomosis. So that's, the indications for transplenic portal or recanalization of the portal vein, and sort of the technical approach into what we're looking for. So on follow-up imaging, we want to, say that this was recanalized and if there is reocclusion or not. He said the reocclusion rate is very low after he recanalizes these portal vein. And then we should raise this as an option if we see portal vein occlusion that's either grade 2 or grade 3.
Nice, Nelly. Our transplant surgeons also have us show them on coronals, and they always talk about this 1 centimeter margin. They make us measure.
Nelly, I have a question about your case, if you can pull it back up. So you're saying in your case, there was chronic thrombus of the portal vein, and I have two questions. One, he recanalized it, but then why did he do it tips? Like he did the tips because of the ascites, or that's part of this recanalization?
It's part of it because he has to keep it open.
Got it. So that's what keeps it open is the tips. Got
Yep,
it.
it's the stent. Yeah.
And does it matter how chronic it was? Because I don't even see, like, I see a bile duct there, but I don't even see like the old portal vein there. So, like, does it matter how chronic it was? Like,
it's for chronic portal vein thrombus, and so like I guess your question about how chronic is it? I don't know if there's a time limit to it. As long as it's grade here, let me pull up grade 2 or grade 3. So you can have like chronic like this patient had. It feels like the whole main portal vein is like occluded, right? And it was.
Yeah, that's why it's amazing to me. Like if there's nothing there, like it's obliterated.
Yeah.
What do they reopen? But I guess they can reopen that obliterated thing.
Yep.
Cool.
Yeah. As long as he's the SMB and the if these are out, then he can't recanalize them, especially the splenic, obviously, because he's going transplant approach.
Very cool.
This meeting is being recorded.
So this was interesting. 30-something-year-old female from a South American country moved recently to the United States, came in with abdominal pain and swelling. She had had a C-section, and she says ever since the C-section, which was 10 years prior, she's had drainage from her lower anterior abdominal wall at the scar side. So we did a CT at first. And I just want to know what people would have called this on the CT. And I'll tell you what differentials we gave.
Can you show the coronal?
Yes, hold on, let me stop sharing. So somebody said foreign body granuloma. Yes, that was a thought we had. We were not sure what these hyperdense things inside this collection were. There was one collection here, and then there's this other one with similar sort of layering hyperdensities.
I'm going to throw in there infectious because you said the patient was not from here.
Right. Yeah, sure. We did that too. But few other things.
The scar draining and the ovarian lesion made me briefly think about like a scar endometrioma, but it looks more like a fluid collection.
So
I don't know why
at an outside hospital, they called the same thing to Aarti. They said, do think about endometrioma, which is a good thought. So then we did MRI. And then here are these collections on MR. So it looks like they're splaying the abdominal wall muscles, the superior one at least, and the inferior one was not that easy to see. It's just a little bit. And that looked like there was a connection to the serosal surface of the uterus. So we're not sure what that meant. Like Nelly said, one thing we thought of was unusual infection. So there was no IUD history or anything for things like actinomycosis to come out and do these sinus tract type things. That still wouldn't explain what this was.
Echinococcus can, but I don't know. I haven't seen it.
Okay. Okay, so we thought of echinococcus, and then I was
Do you have
very
the T1 and diffusion?
Yes. So here's diffusion. It showed significant restriction more at the periphery. I'll show you pre-T1. It was not bright at all.
TB?
Yeah. So TB is a good thought.
Amoeba?
So,
just gonna name
I know, right? No, I even gave Tina
Ascariasis?
she said she was from a pork eating place, like an endemic place with a lot of pork infection. So we said, hey, this is an intramuscular cystic lesion. Why not throw in Tinea solium? So the antigens for that were negative. But when they aspirated this fluid, IR called and they said this was like chylous fluid, almost milky. My resident said it was like dilute cream cheese in consistency. So we thought of hematoma. On the CT, actually, we were concerned, was there some like even underlying tumor, because it looked like solid components, but that cleared up on the MR. And then finally, somebody said it already, right? It ended up being TB. So these were just cold abscesses that had formed in the abdominal wall. I don't know why it looked like it had fistulized to the uterine serosa. Maybe this was a scar site, so it was easy to form and dissect. But this ended up being TB, and her PCR came back positive, and she's being treated as TB. I know we're used to seeing this in the psoas or paraspinal muscles all the time. And usually there's discitis, osteomyelitis if it's in the paraspinal muscles. Not seen one in the abdominal wall muscles like this.
Wow. So, and did you say cold abscess?
Yeah, because it's not, I don't know, I can't remember why they call it cold. Cold, yeah. Because I guess they are not as
think it's 'cause
aggressive
white,
as pyogenic abscesses.
I think there's something with white cells not
Yeah,
activated,
yeah, like
if I remember correctly, some
dormant,
weird
right?
stuff.
Yeah,
Yeah.
correct. Yeah. It's like happens over a long time. We've seen this in the neck muscles also.
Yes.
So
Isn't that
another
what's called scrofula up there?
scrofula, yes, with the lymphadenitis. Those are my cases, Aarti.
Awesome. I have a quick one, unless Nelly, do you have another one?
That's it for me.
Okay. Okay. This was a youngish male with abdominal pain. Just make sure. Yep. Okay. And we only have a non-con right now.
There's kind of a lot happening in the porta hepatis area.
Yeah, good, good, good. So we're just losing a lot of fat planes here, right?
Yeah, yeah.
So all those fat planes and like, I don't know, smudgy stuff here. So I think this could be easy to kind of blow by on a non-con, but we got it. And okay, and then move this up to make sure I don't share. Okay. This was them 2 weeks later.
Something mucinous or
Okay.
some
Good
weird
thought.
infection.
So you were seeing lots of like fluid filled structures, kind of like confluent adenopathy that had rapidly progressed in 2 weeks.
I'm going to throw in their infection too, because it's, yeah, initially I was like pancreatitis, like gone crazy, but it just looks weird.
Okay, what kind of
not enough, like necrotizing pancreatitis, but I don't know why it would be like loculated appearing in the retroperitoneal lymph nodes, or maybe it just kind of dissected into it. I don't know.
Okay. So we've got necrotizing pancreatitis, mucinous infection. Any particular types of infection?
TB.
Yes, this was also TB. I was going to say, I have a companion to your case, Roopa, but I wanted to keep it a surprise. So anyway.
Nice, Aarti. This one's going into the psoas, I can now see.
Yeah. And it's pretty crazy that it progressed like this in 2 weeks. So this is like, I don't know, active, TB. So anyway, this patient actually was immunocompromised, had AIDS, and this was their AIDS defining illness, was this active TB. So think about TB when you see necrotic lymph nodes in the retroperitoneum, psoas abscesses, like she said, osteomyelitis. They can also get peritonitis, which can be dry or wet. So you can get almost like a mucinous, like pseudomyxoma kind of look, or just like fluid filling the abdomen, or you can get dry TB where it looks like peritoneal disease with nodularity. But this was TB. Somebody said, Victoria says, awesome, have to leave. And she also had said earlier that she learned about that Yerdel classification just yesterday. So it is spreading fast. Okay.